So good morning, everyone. I am here today to talk about my master's thesis work. When I wrote my slides, I didn't know that I'd have to write a bio, so my first real slide is about me. I know I'm not wearing the same shirt now as I am in that photo. I just really like floral prints. I've been an activist and a researcher in HIV and queer communities in Halifax for the last 8 years. I did a Bachelor's of Science and a Master's of Arts in Health Promotion at Dalhousie University. We're going to come back to this graphic in just a moment, but first I want to talk about health promotion. I define health promotion as changing the world in such a way that we make people healthier. One classic example is cigarettes. We wanted people to stop smoking. We didn't just ask them to stop smoking, we changed the packaging, we limited advertising, we added tax, and we restricted where you could buy them. All policies to reduce people from smoking and improve their health. Changing the world to make people healthier. That's health promotion. That's what I studied, and that's why my master's thesis in health promotion, I wanted to learn about how older gbMSM understand and prepare for end of life. And when I say end of life, I mean one's anticipated demise. End of life planning is not, nor should it be, just for older adults, but most people, barring an incident with severe illness, don't start thinking about it until they're older, and they start to see that there are, as Captain Picard said in Star Trek Generations, there are fewer days ahead than there are behind. End-of-life planning encompasses a host of options, from funeral planning to emotional preparations, to discussions with caregivers, to financial requirements, to legal documents, to how you plan to spend the last few days, years, or months of your life. So I wanted to explore the challenges that older gbMSM faced and how, or if, their struggles were different from the regular struggles. And since support networks play such an important role at end of life, I really wanted to know more about those. So the standard model of support networks is usually like someone's children. You get older, your kids take care of you, but that isn't always necessarily true for queer or trans older adults because they may not have kids or they might be distanced from them. So I collected my data through the Fostering Conversations study. It was a national study looking at older LGBTQI2S adults in 5 sites across Canada. Each site had focus groups for older gay and bisexual men, older lesbian and bisexual women, older transgender adults, and service providers. The focus groups for discussions were usually about 2 hours long, facilitated by research team members. I co-facilitated the men's group in Halifax, and it sometimes got heated. For the numbers, for those of you who like quantitative stuff, we built participant profiles through a screening tool and a questionnaire. And I focused on the gay and bisexual men's group, which included 40 men across Canada, most of whom identified as gay. Disappointingly, we didn't see much diversity in terms of ethnicity or racial representation. In Halifax, we only had older white men, for example, which meant I can't really do much deep analysis on intersectionality in relation to those issues. The average age of participants was 70, with their youngest being 60, and our oldest was 88. 6 participants self-disclosed that they were HIV positive. 1/4 had been told by a physician that they had depression and similar results for anxiety. 2/3 of those who participated in our study were single and or lived alone. Almost 1/4 of the study did have children, though. And for education, 22 completed university, including 15 graduate degrees. And what did I do with the information that they gave me? Well, I did some data analysis. I am more of a qualitative research kind of guy. No, I like numbers matter, but I want to know about how life plays out at the individual level. So I use qualitative description, which focuses on using the language that participants give to explain their perceptions and understand the specific social phenomena. It works really well with focus groups when there's purposeful sampling, which was true of the fostering study. I combined that with basic thematic analysis, where I coded the transcripts and then used those codes to develop prominent themes. These codes weren't prescribed. I didn't know going in what they were going to be. I mean, I had some idea. They developed inductively. Wasn't trying to test an existing theory or model, but just allowing the data to step forward and tell me what I should be hearing. Themes were then sorted into barriers and facilitators. So barriers were generally created by broader social impacts on individuals, with the effects of heterosexism as an underlying cause for many of the challenges participants faced with isolation and systemic issues. Some barriers arose from the impact of aging or bureaucratic processes related to end of life. And isolation from community really can influence challenges older gbSM they encountered with systemic issues, Without connection to community members, they may have decreased access to resources to help them access culturally competent and care and services, which exacerbate the systemic issues. For example, if you don't know where to find the gay-friendly doctors, you might have a gay unfriendly doctor that creates more issues for you. Facilitators did tend to be more individualistic. Resilience was a major theme that developed during the coding process. This theme is closely tied to the evolution of identity and survival that developed over the lifespan. But let's talk about the graphic I had up before. Ecological models have a lot of strengths and relevance to health promotion. Basically, they recognize that individuals are acted upon by many layers of their environment. But this is inverted, or reversed if you prefer. While the standard social ecological model is great for describing how our health is impacted by our environment, it isn't designed for how we're going to change that. So in 2015, Golden and colleagues proposed this inverted, oh, it's gone too far. Get back there. So, social ecological model for health promotion and intervention. And you'll notice on this model, the individual's at the edge. So rather than seeking to create personal behavior changes, I'm not going to ask you to change your behavior. We want to look at creating change at policies, and then that will ripple out to the individual. And this is one classic example. This is this smoking, as I mentioned before, or seatbelts. We didn't ask everyone to start buckling up. We made it a law, and then people followed, so that they, didn't get fines. But ultimately, we reduced injuries for those who were involved in car collisions. And this model can be scaled to any level. So, for example, you could look at it at a national level where the policy's environment might be the federal government, and the individual, well, is still you. Or in a long-term care facility, the policies and environments might be the bylaws, the code of conduct, the operating procedures for the long-term care facility. And then decision-making bodies might be the board of directors or the executive committee. And then advocacy groups could be unions within the long-term care facility, and so on. So what did older gay, bisexual, and other men of sexual men suggest? Well, they've lived through great adversity, and my focus group participants, at least, were still passionate about fighting for the good fight and improving their lot and the lot of others in life. Based on the data analysis, there's no one-size-fits-all solution to all of their needs, but some solutions do overlap. For example, if you have a workshop to build self-efficacy to support resilience, it can help foster personal connections, which help reduce isolation. You can educate older men on how to navigate systemic issues and help them adjust to the changing nature of their identity. So let's dive into what they suggested as potential solutions to help them at end of life. The first one was gender and sexuality alliances. So isolation was a real challenge for older men in my study. It represented a sense of disconnection from others, including a sense of loneliness or lack of community. Many saw their friendship circles shrinking with no opportunity for growth, experiencing a disconnect from other older adults and younger gay and bisexual men. And obviously, isolation can have a serious impact on overall mental health, which can also impact your physical health. So one solution that came up was creating GSAs in long-term care sites. So GSAs started in high schools and originally meant gay-straight alliances. Nowadays, they're often more referred to as gender and sexuality alliances to be more inclusive. There are social and educational groups that have already begun forming in some long-term care facilities. I believe one of our participants in Vancouver cited one here. Participants saw GSAs as a potential means of making new friends, building a new support network, and an access point to the broader queer and trans community. It could also help educate other straight, cisgender, heterosexual residents of long-term care facilities. Lots of men expressed concerns about experiencing homophobia in long-term care. Not so much from the staff, although the staff were a point of concern, but also from other residents, especially when you consider that they grew up in a time, as one participant said, it was okay to be openly homophobic. Imagine sharing a bedroom with someone who used to enjoy a good game of Smear the Queer. This concept could be furthered by advocacy groups, whether that's outside queer and trans advocacy groups, pushing long-term care facilities, or even internal employees groups. If the examples described in focus groups, GSAs were often started by one person, but that puts a lot of pressure on that one individual. But GSAs would be a great place to host workshops on later life and end-of-life planning. Older men in my study didn't find that their needs were reflected in existing resources or materials. So, for example, I had one gentleman in Halifax who went to an advanced care planning workshop, and everything was about your husband and wife. Husband and wife. Here's this picture of a happy heterosexual couple and your children. And he's like, I'm single and I don't have any kids. And all the language was focused on marriage, and none of this applied to me. Many men reported that as they aged, their primary sense of identity changed. Rather than the focus of their identity being a gay man, it was focused more on being an older adult. And lack of knowledge led to risks of not being prepared for or even recognizing end-of-life concerns. So if there were more culturally informed workshops to prepare them for later life and end-of-life, we could see them better prepared and more resilient to adapt to the changing nature of their identity. Sorry to put all the work on advocacy groups again, but this includes both queer and trans organizations and organizations focusing on older adults. Both need to help prepare older gbMSM prepare for end-of-life. Personal networks can fit in very easily because a lot of people that I spoke to didn't look to organizations for information, they asked a friend. They don't Google things, they turn to their friend and say, hey, I want to get a will, who do I go see? And many of those friends were family members. So participants really pushed for a recognition of all families. While most participants did not have children, and many were estranged from their biological families from when they came out, they almost all had families of choice. And yet healthcare and long-term care facilities tend to focus on the legal and biological definitions of family. We need to recognize that families come in all shapes and sizes, and some are made by choice. I mean, not we, but the systems. Being in a hospital can be very scary and very isolating, as can living in a long-term care facility. Having the ability to have more friends visit is a boon to mental health. As well, many of the older men indicated that they had younger friends who didn't understand the aging process because they never saw it. It was hidden behind hospital and long-term care doors. Side note, lots of older men in my study indicated that they intentionally sought out younger men to be part of their personal support network to balance out their shrinking circle of age-matched friends. So we need to change policies in long-term care and healthcare through decision-making bodies to expand family definitions. And teaching will provide them to have better cultural competence, which I know is a loaded term, but basically the men in my study didn't believe that the people who made decisions for them, whether that was at their healthcare level or the policy level, knew or understood their needs. So they had lots of opinions on what needed to happen, and they recognized in parts of Canada things are happening, but they want to see more happening to support themselves and the next generation. They thought regulatory bodies, for example, those who license practitioners, would be a good place. So requiring, for example, doctors, have to do a certain number of continuing medical educations to get relicensed every year. They're like, why not make it a requirement that some of that is queer and trans health? Or make it expand the inclusion of it in healthcare programs. And then in long-term care, why not make it a requirement that you have to go through queer and trans-friendly training as part of your orientation? And part of this is generational because often providers are younger, which also spoke to the last identified need I'll highlight today, intergenerational dialogue. To say that older men were annoyed at how underinformed younger men were would be a bit of an understatement. They think that this is a generation that lived through the decriminalization of their sexuality, the dawn of inclusion of sexual orientation and human rights, the legalization of same-sex marriage, and they've survived the AIDS epidemic, and they don't feel that younger men necessarily understood all of that. They also felt that, in general, the gbMSM community was youth-focused and that they were, by default, no longer part of that community. If they could reach out to younger generations, it would broaden the definition of the community, it would reduce their sense of isolation, help prepare the next generation for the years and battles to come. Now, there's no easy answer to this one. Many participants suggested they'd like to see something, but they didn't know what it was. And I think that falls to all of us in this room. Learn from your elders and teach those younger. Those are just some of the ideas that the men in my study came up with. Thank you very much for your time.